welcome to this session on stalwarts in ophthalmology. We have with us Dr. Harbanslal, who is the Vice President and now will be the incoming President, great phacosurgeon from Delhi. And we all know Dr. Arup. He's the editor proceeding, and he's has a great practice again. And I will be joined by the other people. This is going to be a session where stalwarts in ophthalmology are going to share with you their real life experiences. And some of them are orations, some are keynote address. And to begin with, we have a keynote address from Dr. Awa, who we all know is from Bangladesh, but has really broken what we call the glass ceiling. And she is the president of Asia Pacific Academy of Ophthalmology, a professor in ophthalmology, really a very nice individual and a skilled ophthalmologist. So can we have the first talk by Dr. Awa Hussain from Bangladesh, and she'll be talking about breaking the glass ceiling.
Honorable Chairman, Co-Chairman, Convener, and learned audience, good evening.
Hello.
My parents, my Baba Ma, I would like to pay my heartfelt gratitude, my love, my respect to them. They are no more with us. But I always feel their blessed hand on my head, which gives me strength, energy, and inspiration to break the glass ceiling and move forward. Kumudini Hospital, where I was born, at Mirzapur, Tangail, a district of Bangladesh, which is 60 kilometers away from Dhaka. And here is the full hospital campus, and there is a very big pond. On one side is the staff quarter and doctor's quarter. My father worked at Kumudini Hospital, a multidisciplinary hospital established in 1944 by Rai Bahadur Ranoda Prasad Saha. We had a big family, and my father was the sole breadwinner. I grew up with my 7 brothers in a modest staff quarter inside the hospital complex. From an early age, the value of education and hard work were instilled in us by our parents. This is my school. I spent my glorious time, my childhood, my adolescence, and part of adult. There I taught how to maintain the time. We woke up at 5 o'clock in the morning and then goes to our work, and how to eat without doing a sound, without sound how to eat. That also a very big dormitory, and our teacher always supervised us and taught us. There we have only 2 months summer vacation and other short holidays, that is Puja and Eid. Otherwise, we spend their whole 10 months' time. During that time, the summer vacation, one day I saw a lineup of patients at the hospital veranda. They were just holding the shoulder in front of the person and going to some places. I had to find out what was going on. I went inside the ward and was told that they were blind and they have come here for treatment of blindness. A couple of days later, I went in the ward and find them. They were so happy and joy in their faces, and they talked with each other. I just asked them whether they can see. They said, yes, we can see everything. We can now eat ourselves. And their happiness, that day, a seed was planted in me. This is my college, Mymensingh Medical College. Here is the hospital, medical college, and we are in our classroom. You see, that started December 1970, and everybody knows that in 1971, we had a liberation war, and 9 months we were nowhere. What is the condition? I don't go in details at that, but I would like to say, he's my youngest brother. He lost his hand, right hand, during this liberation war. He had 3 bullet injury also, one in the right thigh, one opening and one outlet, 2 big wound, and one in the lower abdomen in the inguinal region, and another at the back. My father was also accompanying with him, and one of his immediate elder brother. What he did, he started to write with his left hand and stood first in all the annual examination thereafter. And lastly, he stood first in the board examination, in SSC examination. In 1979, I went to my head of the department to request him to recommend my name for a training post. He said, being a woman, it will be possible for you to do all the responsibility of a training post? I said yes, but he was not convinced, and he didn't say no, but he didn't say yes also. So I was thinking for an alternate plan. The plan that was give me a training post. What is that? That is to do the Part 1 fellowship first, and then that was a guarantee for a residency placement. But it was highly competitive program, and even getting admission was extremely difficult. I succeeded to get admission and ultimately passed the Part 1 exam on the first attempt to secure my spot for the residency. After that, I was placed for the residency training program in the National Institute of Ophthalmology. I took this great opportunity to learn from the very best and develop my skill. After completing the residency and the fellowship part 2 course, I finally passed the rigorous fellowship exam in January 1985. In the middle, my mentor, Professor A.Q.S.M. Harun. He was the pioneer of microsurgical technique in Bangladesh. In 1985, I became the first female fellow in ophthalmology in Bangladesh. Today, the number has grown to over 200. And my student now, they became the professor of ophthalmology. Here are all present here. I am proud to have inspired many women to consider ophthalmology as their specialization. And nowadays, the residency is in such that out of 150, 80 are female and 50 are male. This is the convocation. So, getting exposure to the modern technology at Orbis Flying Eye Hospital during March 7 to 31st in 1985. For 3 weeks, I was deported to that plane to bring all the patients from NIO to the plane, and also after surgery, took back to the NIO. So in this period, I learned a lot of things because posterior chamber intraocular lens implant, I've learned from that plane, and also vitrectomy. Training opportunity at the Princess Alexandra Eye Pavilion, University of Edinburgh, UK, that in 1986, that also updated my training. And the training opportunity in the Institute of Clinical Ophthalmology, Kirio, Japan, 1988. He's my mentor, Dr. Momosi, in India. Maximum person know his name. And here are all my mentors, Professor M.A. Motin. This name I think everybody knows. Professor Ahmed Sharif and Professor Mustafizur Rahman and Dr. Momosi in 1989 in one of our annual national conference. And I always try to learn the best thing from all of my mentors. My first publication was in 1986 on retinal detachment in the Index Journal of Bangladesh College of Physicians and Surgeons. And I have started my surgery from then onwards. He's Professor Mudassir Ali, another mentor. And this is the Orbis, just few years back, last came in Chittagong, Bangladesh. I found teaching to be one of my true callings. I always taught my students with a very dedication, honesty, sincerity. It is over 40 years I am teaching undergrad and postgrad students. I taught and supervised postgraduate students at the National Institute of Ophthalmology for around 2 decades, provided guidance for research protocol, mentored aspiring ophthalmologists throughout my career, contributed significantly to ophthalmic policy development on a national level and beyond, played a stewardship role in the National Eye Care Program, advisory role in prevention of blindness survey in Bangladesh. Now, As I was at Mirzapur, and my father worked there for around 40 years, or more than that, as because there was, at that time, no retirement age. And I preferred to do some voluntary work at Kumudini Hospital. I taught the student, I performed surgery free of cost, and trained some staff of ophthalmology department. I got involved in the Ophthalmological Society of Bangladesh from start of my career and moved up the ranks over the year. Treasurer 3 consecutive terms, Secretary General, President, and now advisor of OSB. I am also the founder president of Bangladesh Community Ophthalmology Society. I regularly communicate with my senior, my junior, my colleagues, my friend, and give the prompt response to the email with a very dedication, promoting professional development, developing leadership qualities. I became the president, SARC Academy of Ophthalmology 2011, chairman, Registration Committee, APO, 14th Congress, 1993, Dhaka, Bangladesh, regional secretary, APO, 2009 to 2019, council member, chairperson, WIO Standing Committee, vice president, president-elect APO, 2019, and President APO Virtual Congress President in 2021, advisor to the Women Ophthalmology Worldwide. First ever women president-elect in the Asia Pacific Academy of Ophthalmology in its 62 years of journey. This is the SARC Academy of Ophthalmology conference, taking charge from Professor Daud and Professor Rajvardhan Azad is the Secretary General. This is the memorandum signing, and here in India, Hyderabad, it is a greatest opportunity for me, as because I was SARC Academy of Ophthalmology President, and His Excellency, Honorable President of India, Sri Pranab Mukherjee was the chief guest, and Professor Rajvardhan Azad lighting the lamp as a Congress President. This is a lovely occasion, as because India, the hospitality which we receive is unique. This is the photograph 1993 with our Professor Arthur Lim, and again with Professor Arthur Lim Dennis Lam in Golden Jubilee. Just giving a president-elect nominee speech in 2019, and after that elected president-elect. And I'm very grateful to all the Councillor of India and all over the APO region to cast me vote 100%. That was really 100%, and I became the president-elect. Some award, Ali Memorial Award, Mubarak Ali Gold Medal Award, APO Distinguished Service Award, Arthur Lim Named Award, Achievement Award, APO, Sushila Bishal Memorial Award, Lifetime Achievement Award, and feeling honored to receive the honorary fellowship of All India Collegium of Ophthalmology, FICO, in 2020, one of the top 100 women in ophthalmology power list 2021. Just receiving the Alim Memorial Gold Medal from Her Excellency, Honorable Prime Minister Sheikh Hasina. And this name I would like to say, Dr. Alim Chaudhary, one of the greatest freedom fighters who was killed brutally during this liberation war, just one day before the Victory Day. Dr. Nuzhat is here. I'm taking just 1 minute, I will finish it. Dr. Nuzhat, his daughter is here. She is Professor of Ophthalmology, Vitreoretina. This is the Arthur Award, some award, and I am really quite fortunate in getting unconditional support from my husband, who is always supporting me from the very beginning after our marriage, continuously inspired me from the very beginning of my career to attend all the conference of Congress and learn much more. My son and daughter-in-law, I never call daughter-in-law, always we think as daughter. And my two lovely granddaughters. With these few words, thank you so very much. Thank you.
I think it would be really fitting to give a standing ovation to this wonderful person who is representing APAO from this region. Didi, thank you very much. And I must say that Didi is not only an inspiration to everyone in her country, it goes beyond the gender, and she's an inspiration to every individual ophthalmologist in West Bengal, in Bangladesh, and throughout India. She's a very, very dear friend of all our stalwarts in India, and the biggest attribute that I can say, a person so high in the ladder of excellence, yet the warmth, the love, and the humility is something to learn from. Thank you, Didi, thank you for coming to us and coming to Mumbai for DreamCon.
Thank you very much once again, ma'am. I'll now request, and I have the honor and privilege to introduce Professor Dr. Atul Kumar for the C.N. Shroff Oration Award. Professor Atul Kumar has really taken Indian vitreoretinal surgery to a great level, and we still remember he's my senior from modern school, then All India Institute of Medical Sciences, then we joined together as faculty, and he rose to be the chief of RP Center. But that was the time when we were starting new things in RP Center, so we were looking at phaco, and he was the master, I would say, for vitreoretinal surgery. A great teacher, great academician. Above all, I think he has taught so many people and has taken vitreoretinal surgery to a new level. I'll request Professor Atul to kindly let us know about his journey, his journey as regards ophthalmology. Atul.
Thank you, Maipal. Thank you, Partha. And thank you so much for all this nice introduction, and my good colleagues and friends. I'm just going to give you a short 10-minute brief interview, talk. I would be covering many topics, many parts of my career and my life, but just a few slides to show some of the few things which happened. So, of course, as Maipal said, why do we all choose ophthalmology? Why do we choose it as a life career? Why we choose that it's going to lead us to some, satisfaction in life? Because once you choose a particular branch in medicine, you stick to it. So it's medical and surgical, treating both wellness and disease. And also the very fact that it spans all ages, the range of the diagnosis is broad, the technology is breathtaking, innovation is constant, as I witnessed over these years. So that's why I just took it as a good option, I thought. So I was born in 1956, and as Maipal mentioned, my early schooling was in Delhi itself, in modern school, Barkhamba Road, where Maipal was also there. So we were under the illustrious Mr. M.N. Kapoor, principal beyond words, and he kind of groomed us to be disciplined, proper persons, and also be very academic in our approach. I did my MBBS from Maulana Azad Medical College and then moved on to do my junior residency at MDA from RP Center. Then did my senior residency or registrarship from 1984 onwards in RP Center for 3 years, and then joined the faculty as assistant professor at RP Center. It was lecturer at that time, but redesignated. Finally, 2016 to 21, I became chief and professor at this particular institute. This is one of those early pictures where you can see Mahipal there also as a resident, Rishi on his right side, Auric on his left side, and Dr. Murthy is there, my wife is there, myself. Professor Madan Mohan, we used to adore a lot, recently passed away, then Manoj Rai Mehta. So this is a place where in RP Center, in the front where we used to have our dinners. Of course, it was a very nice place because we would all get together in a area where the residents used to all get together, or the faculty. So my boss was also there, and so this is just to tell you, I jumped many decades and years and then became chief. So then we just inaugurated, when I became chief, the Plaque Brachytherapy Center for retinoblastoma, melanoma, which we didn't have before, and also the state-of-art retina center, the lab there, where we put in all the diagnostic and therapeutic machines, as well as a research lab for retina. So we got, in 2016, as soon as I became chief, I got RP Center reappointed as a WHO collaborating center, which we had lost before. And also conducted a survey on diabetic blindness along with the ministry in 2015 to 19, first of its kind, to assess the magnitude of DR in pan-India, entire India. Also took AIMS, RP Center basically to the top level hospital, and then a major milestone was my receiving it from the distinguished Dr. APJ Abdul Kalam in 2007, much before my chief, before I was even, I think, associate or professor, as a professor. So my Padma Shri, I think the same year, Padma Shri, Mahipal had also got, and so did Anup Mishra, if I'm not mistaken. So anyway, then I got my FRCS at Edinburgh in Hominium from the president of the Royal College of Surgeons at Edinburgh. And then, of course, teaching has always been my passion, and one reason why I stayed on was to teach and train postgraduates in retina. And we used to have workshops and PG teaching series. And there was a ban on bevacizumab due to cluster endophthalmitis all over India. So the DCGI put a ban. So we got them to somehow talk to them and revert or call back the ban, or the kind of, they put a ban on use of Avastin. Avastin is economically very viable for patients of our country. So with the DCGI, with the lobbying we did, I was one of the major factors, along with the others, Ajay Roda and a whole lot of other people, Dr. Vishali Gupta. We got this ban, or you can say, the off-label use was banned by the DCGI. We got it reversed. And that's the reason why Avastin is still being used. Though the company Roche doesn't allow it, it's written clearly in the instructions not for ophthalmic use, but because of DCGI position being towards our side, we've been using it off-label. But of course, you need a consent. So these are few things. We did a 50th Golden Jubilee, very successful at the RP Center. Luckily, it fell during my career, my duration. So I've taught a lot of residents and resident-to-resident teaching. I've tried to simplify residents teaching and also written books on retina, comprehensive retina for medical and surgical management both. The latest edition is a 2022 edition, which has just got released. And make it simpler. I've treated a whole lot of distinguished people whom I've always adored, and now I'm continuing my work, because something not to look back is to continue my professional work and patient care, free from all other things. And this is the center where I work at Housing Enclave, and with my small team, and we are doing reasonably good work. And we use a digital Ingenuity system for VR viewing and VR surgeries. Basically a retina center with some cataract, but no refractive or cornea work. So this is the kind of work we are doing there. This is just from the screen, video from the screen of the 3D viewing system, the flat OLED screen. So just to tell you what all we are doing is right now. So we have a OT which is state of the art, and dedicated retina OT where only retina equipment is kept and no other surgeries are done. So I also got the BC Roy Award from the late Dr. Pranab Mukherjee, and he was a very great moment for me because Dr. BC Roy is one of those distinguished ophthalmologists, doctors who was actually a great man, and he did wonders for India. And on his name, there is an award called the BC Roy Award. So I've also been the consultant to the Armed Forces for retinal diseases and surgery. And during the various terrorist activities, I've treated many trauma cases, which I'm really indebted to the Armed Forces. I've also delivered a couple of lectures to the Armed Forces Medical College at Pune on retinal disorders and traumatic retinal diseases and how to manage injuries. Learning never ceases. I've been a member of the APVRS Retina Committee, and these are with various pictures I've had with them. And this is the place where I now work. And these are high definition retina platforms where we take care of patients of all kinds, because learning and teaching never ceases with this Professor MC Mishra, my former director at AIMS, who recently visited me for some eye issue. And Dr. Deepika Deka also visited me. She chose me for her eye treatment because she needed a lot of urgent eye treatment, which I'm continuing to do. And so I feel very satisfied that people previously also whom I've worked with, or who are my teachers or with me, colleagues, have looked up to me for their care. Thank you so much.
Thank you very much, sir. It was wonderful listening to you, and we thank you for the enormous work that not only you have done, but also that you have imparted to ophthalmologists in our country and beyond. Thank you very much, sir. We call upon Dr. Samar Basak. Dr. Samar Basak, sir, has been another source of inspiration, and he has been the recipient of the P. Shiva Reddy Award for 2021, Director of Disha Eye Hospitals, and before that he was in the Government Eye Hospital and spent a large number of years at the Government Institute, after which he joined Disha, and today Disha Eye Hospitals is a chain of 12 hospitals in the whole of West Bengal, giving a huge amount of human service to the community who can pay but who cannot afford the highest. However, Disha has come with a state-of-the-art eye hospital in Kolkata, which is a real dream come true for the whole place and giving a lot of service. Dr. Samar.
Thank you, Dr. Partho, and please share my slide. Ophthalmology, my life and my dreams. I do not have any financial interest. So I failed in gynecology and could not appear in West Bengal PG exam. That opened the opportunity to appear in PG entrance in AIMS, and my ophthalmology career started at AIMS RP Center in 1984. PG days were most valuable time. I learned a lot from my teachers. I married, passed MD, joined WHO fellow, then joined as SR from January 88, dreamed to be a faculty of RP Center, developed passion for cornea and eye banking. It was my PG thesis. My guide, Anita Panda, gave me first PK, rarest in those days, in my 5th semester. My first keratoplasty in my career. Patient from my own town, Bengali. And these are 2 photographs of the same patient. I did another eye after 7 years when I joined in NRS Medical College. Before joining ASR, 30th November 1987, red letter day foreman, I had a malignant vasovagal neurocardiogenic shock. While investing in their cardiac cath lab, I had cardiac arrest. CPR for 2.5 minutes, 2 rib fractured, temporary pacemaker, followed by permanent pacemaker after 3 days at the age of 29 years. Reported as a case report in their journal as the rarest entity and probably the first case report from India. So life changed, so the destiny. So by the family pressure, I came back to Bengal and I joined West Bengal Health Service in a rural PSC. GDOMA, no ophthalmology, forget about cornea for 5 years. Every day was a no day for me. Learning everything of life except ophthalmology for 5 years. I started writing books, completed my family. Then, after 5 years, I joined as an RMO cum clinical tutor. My love, my teaching, etc., used microscope, reopened eye bank, my first paper published, wrote UGB. This is my first paper, first book in Bengali for layman. This is my first book for undergraduate student, and believe me, this book gave me double money than the salary in that year. Then the conflict started in me. It is a job or it is a career. Job is just going to work and earn some money. NRS posting was just like a job for me. Every moment there was obstacle and you know that it was boring. Then the politics of next posting. Whereas to me, a career is a journey that includes your job, experiences, learning, training, teaching towards your attitude to fulfill your long-term dreams or goals. Then there is a glittering call from this man, Dr. Devashish Bhattacharya, who resigned. This has started in 1st May 1997. The best part of Devashish is that he has given me full freedom and a playground so that we could play freely with our passion. Then there was challenge because Devashish's practice was cataract-based. My dream and passion was cornea and eye banking, but he gave green signal cross-subsidizing the cornea and eye banking that go ahead. No fellowship, no SRship. I realized that a good lab and robust eye bank are the only two important things required for complete cornea. Struggle, literally begging everywhere for a pair of donor cornea. Today we are the 3rd largest eye bank in the country, 3rd largest transplant center in the country, that to a subdivisional town. Learning corneal surgery, self-learning is most of my cases. Everybody is my mentor actually, so to say. Learned web lab concept, goat's eye, and goat's eye, every day 5 to 10 surgeries in a week, and the power of observation. Our saying, if they can do it, if he can do it, then we can do it, and I can do it. Devashish often says, it is in Bengali, Oder mathai ki shing ache. So I also believe that. PK, DAL, LK, DAL, DSEC, DSAK, DMA, KPRO 1 and 2, these are my area of keratoplasty procedural. Then you need documentation and creating database. Used to show my work to other people, paper, poster, video, participated extensively in state journal, AIS forum to have referral only. And finally publish. Unless you publish, your work will die. And these are my beloved patient. I often enjoy this beautiful photograph with this, many of my patients. Publishing is important. It keeps you updated, the way to move forward. Those are also silently added to your CV because of today's cloud era. And attending conferences is also important. AIOS and AO every year since 93 and 2001. I've learned so far mostly from AIOS and AO. Be focused, attend the conference, you will learn a lot, and you will get real recognition. You will have your new academic circle. I have amply awarded by AO and AIOS. Then honorary FRC is just like they gave me. No one was known to me. Because of CV, they have just send a form and fill up and send it to me. And they have also selected me as FRCS examination by a short interview via email. I am enjoying that. And because of that, my books also helped me a lot, going to the basic root level. These are my book, my passion, 8 books, 4 chapters. And these are the series of books. You know, there are 2-3 books which are very popular among the MBBS students. This is the latest edition published, and I have just seen it in the JP stall. And you know that it gives me my respect and huge recognition. Forget about the number. There is unending satisfaction, and tax-free royalty comes as a byproduct. My hobby is philately. I love history of ophthalmology. When I read those things, you have received my mail, starting from Egyptian ophthalmology to Ghanaian era, and you know that now we can go much deeper because of Google Master. And you know, those people are great. We are just nothing. We are copying their activities. My hospital output, I am not a very bad surgeon. The hospital people, admin also, this is my yearly data, last year data. So I am very big volume cataract surgeon as well as big volume keratoplasty surgeon. My dream, 1,000 corneal surgeon, everyone is doing 100 graft every year, 100,000 keratoplasty per year. And this is also the Vision 2020 prevalent. Probably you have received this kind of mail from me, but we are reluctant about the eye banking. And unless eye banking is there, you cannot have very good corneal surgeons. Are plenty now in India. They are just waiting to get a pair of tissues so that they could go forward. 2 most important words for me: count, number. Count your number of success as well as your failure and complications. For learning, for improvement, for innovation. Important for professional growth, important for individual and also for institution. The other favorite words of me: better. I don't believe in best. Time. Attitude. If you add this attitude numerical of it is 100, that means if your attitude is right, you are 100% right in your goal or dream. Then the long term, it is also very close to my heart. And you need to know the time management. So I sit back sometimes. This is my extrapolate of my chest. There are 3 wires in it. One is sitting there for 35 years. 2 are sitting there for 15 years. And 3rd generator is for 5 years. Sometimes I look back to this plate and think about that 35 years of extra life, and life is beautiful. Your career is a journey, not a job. Dream and enjoy the climb. Thank you very much.
That was really wonderful, sir. Wonderful journey. Thank you, sir. Now we would like to invite Professor Jay Estetia. He obviously needs no introduction. Padma Shri awardee, my teacher. Whatever I've learned from him. And he's an excellent surgeon, excellent teacher, excellent researcher in the field of cornea, cataract, and refractive surgery, and chief of RP Center and advisor to Government of India. Professor Estetia, sir.
Good afternoon. Thank you, the scientific committee, Dr. Partha, Dr. Rajesh, for such an honor for me. It's such a coincidence sharing this Peace Equality International Award with one of the most dearest friend, Dr. Samar Basak. In fact, we started our journey together. We have been together in RP Center for such a long time. Until date, we are together in our journey. And we have learned so much from each other. And it happened that we shared the same award last year. So my dream in ophthalmology has been nothing new, but it is always important to keep pace with the evolving technologies, which changes the life of a surgeon, clinician, practitioner, and that translates into a life of a patient. And you should never shy away from the innovation which is happening in your area of concern. I'll be talking on my area of concern has been 3 basic areas. First was cataract surgery. We all live, die for cataract surgery, and earn bread from a cataract surgery only. But there are few other surgery which has become so prominent in last few decades. Refractive surgery, and last for less than 2 decades, the keratoplasty surgery has become a livelihood of many, many people, not for surgeons, for patients, as Dr. Basak talked about. Without a change, there is no innovation. We know that. You have to be a creative. You have to look for how to improve situation around you, and that will give you innovation happening in life. So this is my journey, started from 1984, end of 84. I joined in January 85. We started with a simple intracapsular surgery to a modern day refractive surgery, refractive cataract surgery, which was actually compounded by image-guided surgeries, lasers, and went through the entire gamut of a change. So this is what we used to do, a camp surgery, torchlight examinations, and it used to be a wonderful fun those days, and actually we gave a lot of vision to so many people across the country. That was a requirement. Now things have changed. You have a high-tech instrumentation. Surgery has become faster, not only for surgeons, for a recovery of patient has become faster. People actually say thank you after doing such a beautiful surgery on their cataract. Femtosecond laser has changed the concept of not the surgery, but concept of a precision of getting things in a correct manner. And what better than an image-guided surgery which tells you where you have to put your hand, where you have to put your instruments, and where you have to implant the IOLs. Nothing was visible inside the microscope which we used to use. AIOC2022 had changed, and recently the digital 3D systems has made life so simple, not only in a routine surgery, during COVID time, and teaching tool is one of the wonderful things which has happened. Let me take you through all these things which change the concept here. When we started doing phacoemulsification, one of the most important hurdle was to see the capsule in very clear manner. And I don't know who was that person to invent the staining of anterior capsule with trypan blue dye. That changed the entire surgical skill of everybody. We could see everything in a hypermature cataract also. So this is one of my publications based on a trypan blue dye. And second hurdle was to correct the astigmatism so that patient doesn't have to wear a thick cylindrical glasses. And this was one of my, you can say, way of looking to correct the astigmatism by combining the phaco with arcuate keratotomies. And that was the teaching that you can modulate the corneal curvature in a way, place the incision in such a manner that you can decrease the astigmatism in the cornea and patient will see better. But now we know that this has totally been taken away by toric lenses. Third hurdle was the after cataract. We had so many innovations, surgical technique, intraocular lenses, and these innovations gave this type of after cataract, which we named as a fluid after cataract, which normally happens after 5-10 years of a terrifically good surgery and good vision to patient. And this technique where we aspirate the fluid and then do a posterior capsular access to give a permanent clear vision. So there are 3 hurdles which we took away from the patient's difficulties. Then all these intraocular lenses, I had to go through them, achieve the perfection with these designs, these lenses, assess the aberration which may be there in a patient eye, which is not giving good vision to patient, but assess these aberration after surgery also and change subsequently how you're going to proceed to perfection. Femtosecond laser, we knew that this is going to decrease the energy delivered inside the eye and less damage to the cornea, especially endothelium. And we definitely found that in studies that it is effective. If you modify the femtosecond delivery to nucleus, it can also change the outcome in a femtosecond laser also. The incision we all talk about, because which is the best incision was difficult to demonstrate intraoperatively. The microscope which had the AIOC2022 attachment, that gave the entire picture of incision right from the initiation to the end of surgery, and you could really titrate the operative volume, operative change in incision, and the associated difficulties also. And we described that femtosecond incisions, if you do properly 3 planar, they were the better incision in terms of decreasing the wound site decimal detachment in all these cases. Then you had difficult cases. How we generated the new concept with the innovations with various devices. Femtosecond laser, we compared the femtosecond application in the intermittent cataract with the normal capsular access, and we found that they were equally good. Only thing difference was in a routine manual surgery, you had to do multiple steps, sometimes 2-stage access, or sometimes you have to initiate the small opening, aspirate the fluid, decrease the pressure, and do it, while femtosecond was a single-stage surgeries. Then this was another innovation which came out subsequently while doing phaco with femtosecond laser. And this was the, I think, concept which really translated subsequently to my research also in posterior polar cataracts, where we designed the 3 rings for safety and the 8 blocks of nucleus in 3 tiers. The primary tier in the central area, secondary tier, third tier. And each block could be separately picked up, and you could save the entire epinuclear cushion till the last and decrease the dehiscence of posterior capsule. And the type of surgery we could do in subluxury cataract, where before you open the incision, before open the limbal area, you could do a capsulotomy, you could do a nucleotomy in these cases, and do the incision. All 3 things which can change the entire subluxation pattern in the eye if you open the eye could be successfully done with femtosecond laser. And this technique was published. Similarly, this is one of the innovation technique which we could publish in cases with phakic lenses inside eye where cataract had to be done, and we could do a femtosecond laser in these cases also. Other area was how good these modern devices were. We compared the image-guided toric lens implantation with the manual markings, and that gave us the way of looking into the higher order aberration and quality of vision in these cases. And this new tool, which we acquired in around 2015-16, the intraoperative aberrometry, to check the actual amount of power required for IOL, the toric power, the toric axis. After you implant that, you could reassess the aberration profile and change the toricity axis in these cases. Really benefited, especially in our post-refractive surgery surprises. It was a wonderful tool and gave us way to look into. In 2016-17, we acquired the AIOC2022 microscope in RP Center. With that, we could really look into the dynamics of, intraoperative dynamics of various surgical steps of cataract surgery. You could see these pictures of the anterior segment OCT also, but dynamics could not be seen without the intraoperative OCT, and we could describe the various types of white intumescent cataracts. The way you could see this picture, you could never see under the microscope this hill which is coming from the raised interlenticular hydrated cortical matter after you make incision. So these type of picture could be seen with the AIOC2022 microscope. That gave us an avenue to classify the new way of white cataracts. In fact, we have been a winner of AO best video in this category also. Similarly, we could also see the dynamics in posterior polar cataract, redesign the entire classification, and this video also got award from APSARS last year. This is one of the subsequent, you can say, looking into the posterior polar, where we could describe this central cortical disc defect, which is a sign of safety of posterior capsule in posterior polar cataract. Lenses-wise, we had so many generation of lenses coming up. Which lens was better? So we did a stereoscopic analysis of these cases, binocular, to see if their stereoscopic vision is good, because distance near the vision was quite okay, and we realized that they were quite good, they were not bad compared to the monofocal lenses. This lens came with a bang, the Hoya lens, where it said that the posterior surface is treated by ozone and it can get adherent to the posterior capsule. We described the various pattern of a posterior capsule in relation to these lenses, and now we are going to come out with the long-term results of these lenses also. All these research, clinical research, comes with the experience, and it goes with the innovations also. And similarly with the newer generation trifocals also. Recently, in 2019, we acquired these digital microscopes, 3D microscopes, where you could do surgery without the assistant oculus, advantage being high magnification, clarity, and the light which patient is very uncomfortable can be decreased to a minimum to complete the surgery. And the benefit has been really been accepted by all who have access to these instruments, and it is being published in IGO, the benefits here. The major area of my concern is teaching, where we could have a surgical skill area, not only for center, for entire country. And now we have a various, you can say, systems where you can do a simulations for cataract surgery and ambulatory surgery, and do a surgery of all types. Dr. Basak talked about, we have been together, he's been teacher to us also for endothelial keratoplasty. I'd just like to highlight one of my paper which was published long time back. This came before the all intralenticular, you can say now additive surgeries, people implant various things inside the eye, but this was a concept where I reflected the flap of an intraostomal tissue to cover the perforation and put a lamellar graft over that. And in fact, this would be a generation for people accepting this as an intralamellar additive procedure subsequently. Use the cross-linked cornea for a therapeutic grafts in fungal ulcers to decrease the melting happening in these cases. And IOCT in DALK, 3 recipients for 1 corneal tissue. These are all path-breaking clinical research and sutureless DSEC surgeries. Looking into a microkeratome versus the femtosecond laser, we could do a surface analysis with help of IIT Delhi to look into the surface of these and electron microscopy to see the endothelial function in these cases. Just to highlight one very important thing which we could describe was life-changing for a keratoplasty surgeon for doing DSEC. We could actually analyze the time taken for a DSEC lenticle to get adherent to the stromal bed. And this was a case control study, and we knew that if you do a pressurized anterior chamber and the massage from anterior side, you can finish the attachment process within 1 to 3 minutes. And hardly you have to wait for 10, 12, 20 minutes to see that graft is attached. So seeing that thing inside during the surgery makes everything absolutely clear. Like you can see here, graft is so beautifully attached. Same holds true for a DMEC also. You could see the type of roll inside, correct or incorrect, see through the hazy corneas also. The entire refractive surgery journey has been with me right from the radial keratotomy to the recent SMILE surgery. I've gone through all of them, and that led into knowing that what are our learning curves for our various new surgeries, what are the complications we face, and that led into one of the very important article in clinical ophthalmology, the techniques of SMILE, which we could publish, and various signs to see actually how effective you can do dissection is followed by people from across the country and world over to do a good dissection of a SMILE lenticule. And these our experience ultimately resulted into a book which has been published by J.P. Brothers. This is I think, one of my first publication with IOCT. Nobody could comment that what is the orientation of phakic IOLs or what is the bolt on the table in your surgery. And this is what we could see on the table and measure the actual bolt on the table. And this is one of the first publication in literature regarding the intra-op bolt assessment after ICLs. So these are 2 books which have become very popular for SMILE, and the refractive surgery book have come this year only. Already it's become one of the best sellers from JP Brothers. So the journey is long. It's always not a simple. It has ups and downs in your learning curve. But real trump is not that you could do all those things. But real trump is to see that you can train the next generation of your students to become better than you. Maybe they become your own teachers. Once my teacher become my teacher, that's the most satisfying day for a teacher. And same holds true for me also. Other way is to promote research and give an innovative thinking to young generation so that we have a better society in future. I would say in Hindi, this is a quote from Majru Sultanpuri, मैं अकेला ही चला था जाने में मंजिल मगर लोग साथ आते गए और कारवां बनता गया. So if you go alone, it's not that people are not going to join you, they'll come with you and that will make the entire journey so pleasant for you. Take pride in how far you have come, have faith in how far you can go, but don't forget to enjoy the journey. I think I would like to thank you for listening to all this stuff.
That was really fantastic, sir, taking us through your journey and also the journey of evolution in the field of cataract, cornea, refractive surgery. That was truly wonderful. Thanks a lot, sir.
Thank you, Rajesh.
Now we would like to invite Dr. Jyotirmay Biswas, who is a stalwart in the field of uvea, has trained many uvea people and has done some path-breaking research in the field of uvea at Shankar Netralaya, Chennai.
Thank you very much. Thank you for giving me the honor of having the B.K. Narayan Rai Award. I dedicate this award to my teachers and my students as well as my patient. I'd like to start with a quotation. The known is finite, the unknown is infinite. Intellectually, we stand on an islet in the midst of ocean of inexplicability. Our business in every generation is to reclaim a little more land. And what I have done over the 33 years is the little more land which I acquired. My journey in uveitis started 28 years back. So we started with the tuberculosis, and I have made about 16 publications in that one. TB in India is 2 million people develop TB every year. Every fourth patient of the TB in the world is an Indian. Tubercular uveitis has got protein manifestation, can have a small tubercle to a subretinal abscess. Question I asked, what is the ocular morbidity in active systemic tuberculosis? What are the various types of ocular tuberculosis seen? Is Eels disease seen in active systemic tuberculosis? I went to the Tuberculosis Research Center in Madras 1985 and spent 1 year and studied 1,005 patients, and ocular morbidity in active systemic tuberculosis was 1.39% only. Most common was healed focal choroiditis. Interestingly, no case of Eels disease was seen. This was the case of molar tuberculosis of the choroid, which was taken 32 years back. So I started looking into the histopathology department, clinical pathological confirmation of the tuberculosis cases. And I got only 5 cases between 10-year period. So this includes subretinal abscess, granulomatous uveitis with scleral perforation, exudative mass in the anterior chamber, choroidal mass with pan-uveitis. This is a case of a subretinal abscess, which subsequently could not be salvaged and later on lead to the panophthalmitis. When the eviscerated tissue was histopathologically examined, we found myriads of acid-fast bacilli in the subretinal space. We also looked into the new test which came, quantiferon test for TB, and we found that it is superior to the Mantoux test. We studied the ocular tuberculosis in acquired immunity syndrome in our country. It was published in American Journal of Ophthalmology, the first report from India as well as in the world. We found ocular tuberculosis was in the 4.8% cases of AIDS patients. We studied the subretinal tubercular abscess in southern India and found the timely management is crucial. We also published tubercular uveitis presented as a very rare manifestations like pigmented hypopyon, and which was positive by polymerase chain reaction as well as the microscopic study. We studied polymerase chain reaction and introduced that technique in our country with the 27 publications. It's some form of xeroxing of the DNA segment. The first study was done in 2002 when we found a choroidal tubercle in disseminated tuberculosis diagnosed by polymerase chain reaction of aqueous humor. These are 14-year-old girls, sudden dimness of vision for 1 week. PCR for the intraocular TB for fine needle aspiration biopsy was positive for Mycobacterium tuberculosis DNA. And what happened to the patient after treatment with specific antitubercular drug? There is a complete resolution of inflammation. We subsequently PCR study of the intraocular fluid in the suspected tubercular choroiditis. We studied, and which has got the AIOS Nursing Award for best paper in the UVS session. We studied the real-time PCR, which is a fluorescent molecule used to monitor the PCR reaction. Fluorescent entitled by the fluorescent molecule manifolds as the PCR reaction each cycle of amplification. We did the real-time PCR in the eye infectious uveitis, tertiary care center, and multifocal choroiditis, serpiginous choroiditis is demonstrated tubercular tubercular etiology. We did a herpes simplex keratouveitis by real-time polymerase chain reaction. Yield disease, we made 29 publications, which is the most common retinal vasculitis in Indian subcontinent. 1 in every 135 patients in Shankarnetralaya was yield disease once upon a time. And we tried to find out is yield disease due to the tuberculosis or not. We did the PCR study of the vitreous sample for Mycobacterium tuberculosis DNA in yield disease and found around 50% cases was positive for Mycobacterium tuberculosis. We also studied the epiretinal membrane in the yield disease for the PCR detection, which was published in IOVS, Investigative Ophthalmology and Visual Sciences, one of the highly rated scientific journal in ophthalmology. We found 47.8% of the yield disease cases was positive for Mycobacterium tuberculosis DNA. This is the agar gel photograph showing the PCR of Mycobacterium tuberculosis DNA. We concluded that cell-mediated immunologic reaction triggered by sequestered Mycobacterium tuberculosis antigen is responsible for yield disease. We, in fact, found the Mycobacterium tuberculosis DNA in the enucleated eyeball by the histopathologic and microbiological studies like molecular biologic study of the DNA in the MPP64 and I6110 was positive. We also looked at the high-resolution computerized tomography of the chest in identifying tubercular etiology in patients diagnosed with yield disease and found that particular specific tree in bud appearance in the high-resolution CT chest. We read 300 full-text articles and wrote a review article on yield disease and update in Survey of Ophthalmology, and subsequently updated in the Journal of Ophthalmic Inflammation and Infections is the same. We also done the long-term outcome of a large cohort of patients with yield disease, 500 patients, 898 eyes, with a follow-up of 15.8 years, 10 to 25 years. The major finding was bilateral to 81% cases, acute stage oral steroid better prognosis. Intermediate acute stage better prognosis, laser treatment in the proliferative stage, recurrence is 52% at more less than 5 recurrences in 10 years. In intermediate uveitis, which is an enigmatic disease, we describe the pattern of intermediate uveitis in children presenting in the tertiary eye care center in South India. And we also published the Azudex implant and the treatment of non-infectious intermediate uveitis, and you can see that this is a biodegradable material. Study conclusion that was the Azudex implant is a promising treatment for control of inflammation in the non-infectious intermediate uveitis. Evaluation of the cataract surgery in the intermediate uveitis, we found that this can improve the vision in 94% eyes. In serpiginous choroiditis, we have got several publications, 7 publications, and we recently described the macular serpiginous choroiditis. And amphigenous choroiditis is a new entity which was described by us. No large series was available before that. We published the large series of clinical profile, treatment, and visual outcome of amphigenous choroiditis. In HIV, we are the pioneer in the ocular lesions in AIDS in the country, and we reported the first 2 cases in India, followed by in American Journal of Ophthalmology, first 100 consecutive patients, and subsequently 1,000 consecutive HIV-positive patients in India, and found CMV retinitis is the commonest opportunistic infection in HIV-positive patients, even in the heart era in India. Viral retinitis, we had 20 publications, and we found that the acute retinal necrosis, favorable outcome was seen only in 45.1% cases. Parasitic uveitis, we had 21 publications, and I am not able to show the video now. We did that intraocular nephrostomas spinogerum. First time we did that electron microscopic study as well as the histopathologic study of the parasite. Ocular malaria, we described that one in Ophthalmology Journal, and we showed that there's a malaria parasite is seen in the choroidal blood vessels. Kalajor patients, we described the Lisman-Donovan bodies, and clinical profile of Toxocara we have described, as well as the VKH. We have got 5 publications, and we showed that the incomplete VKH is much more common than the complete VKH. Extraocular signs are far less common than in the Japanese population. Recently, we described the choroidal and retinal anatomic response following systemic choroidal corticosteroid therapy using Swepso's optical coherence tomographic also. In the epidemiology, we are the first to describe the pattern of uveitis in referral uveitis clinic in India. This was possible with a very crude meticulous record of all uveitis cases by hand in register, which I did in 1989 onwards, and presented as the first paper, and this was the first series of the uveitic pattern in India. And with 13 years after, we published the changing pattern of uveitis over 2 decades in a tertiary eye care center in India. We also described the pediatric uveitis and challenge in the uveitis, 6.29% of the uveitis cases. Juvenile idiopathic arthritis associated uveitis we have described. Uveitis search for the cause, we tried to find out and found Mantoux test is less useful than quantiferon TB gold test. We also used the high-resolution computerized tomography in granulomatous uveitis and found it is much more useful than chest X-ray. Biopsy pathology of uveitis is my passion, and we have described the various ocular pathologic features of clinico-pathological correlation and various types of uveitis. This was published, pathology study, anterior chamber tap, iris biopsy, final aspiration biopsy, and this is a recurrent primary non-familial amyloidosis of the vitreous. I don't want to go into that one. We described the indocyanine green angiography in posterior uveitis, mutes. Management of the uveitis, we are the first to describe the mycophenolate mofetil therapy in uveitis, triple agent immunosuppressive therapy in VKH. My journey in uveitis to 28 years is, you might guess that who is the person. This was in PGI Chandigarh, 1983 at Sports Day PGI. I was trying to cross the bar, and this is that still the quest for the knowledge continues. Without many of them, I could not do. My mentor, beloved chief, Dr. S.S. Badrinath, who supported me, and my another mentor, Professor Narsingh Rao, Dohinia Institute, USA, who taught me how to write articles, and whom I will never forget is my photographer, S.P. Govindarajan, who did, and host of the peoples who has helped me. And last but not the least is my wife, Dr. Shubhra Viswas, who actually my first article, Primary Non-Familial Amyloidosis of the Vitreous, came. I wrote 7 pages. River asked me to reduce 1 page. I simply couldn't do it. My wife did it for me. Thank you very much.
Thank you, sir. Thank you for letting us know. We all know, but you know, the kind of studies you have done in the field of uveitis is really terrific. So thanks a lot for enlightening all the ophthalmologists regarding in this wonderful field. Now I would like to invite Dr. Sujatha Das. Dr. Sujatha Das is head of the cornea at the L. Prasada Institute, Bhubaneswar, and she is a wonderful cornea surgeon, a terrific clinician, and a very good researcher, has loads of publications. Let's listen to her journey in the field of cornea. Dr. Sujatha Das, please.
Good afternoon. Thanks, Rajesh, for the introduction. I'll be speaking mostly the journey of iBank, which I have spent 20 years almost. Most of my ophthalmology journey started with iBank. So this was my topic for the Oration Care Datta Award. So the dream is to achieve zero corneal blindness in India. So I like to tell this quote: the future belongs to those who believe in the beauty of their dreams. So all of us know the prevention is the best way to control any disease, not only corneal blindness. So once cornea loses its transparency, we need corneal transplantation. However, again, we know what is the limiting factors because shortage of donor cornea. So we need lot of transplantable donor cornea in order to reduce corneal blindness worldwide. You can see out of 2.2 billion people who are blind, at least 1 million, around 50% could have been prevented by taking preventive measures. If you see this graph, Southeast Asia has more than 50%, it's the largest proportion which could have been prevented. And globally, around 50% cornea blindness is from Southeast Asia and Western Pacific. This is an economic burden because we spend a lot of money in treating the disease at the late stage and lost earning not only to the person, also caregiver, finally leading to lower quality of life, social, economic, and health cultural term. So the annual cost of potential productivity loss cost around $410 billion. So out of 37 billion worldwide, blind worldwide, 17 million can be cured by cataract surgery, and which is very success rate, 90-80%. So it's not only restricted to one country or any age. So age, socioeconomic status, anybody can get affected. So if you see this NPCP data, corneal opacity is second if you see age more than 50 years. But when it comes to age less than 50 years, cornea opacity is 37.5%. So coming to cornea blindness, it is more common in developing country, and globally bilateral blinds are 4.9. And India, Africa has much percentage compared to other places. And again in cornea blindness, with time, trachoma has gone down, whereas undetermined cause of blindness have increased from 13% to 21%. In India, keratitis is a leading cause of ocular morbidity. Also, we see keratomalacia. Although there are programs for vitamin A supplementation, we see keratomalacia. Why are we worried about cornea blindness compared to cataract blindness? Because cornea blindness happens in young age, and it affects high disability adjusted life years compared to cataract blindness. In Andhra Pradesh eye disease study, we found cataract, the mean age is 68.5 years, whereas cornea blindness, more than 50% are less than 40 years. So if you see the prevalence of cornea blindness in India, it is almost highest in many, total blindness is almost equal to China, and if you see prevalence percentage is highest 0.68, and cornea opacity, almost every places it is more compared to other countries. This picture I like to present in many of the eye banking forum is pride to have India, although we have more of a cornea blindness, but India is highly ready for to tackle this. Similarly, this also is a slide where it says India is almost sufficient for cornea transplantation. Coming back briefly to the iBank, it's a not-for-profit organization which supplies cornea for sight restoring transplantation as well as for research and education. It has two components. One is administrative section, which deals with the public awareness and funding. And medical section actually has expanded beyond these four: harvesting, evaluation, preservation, and distribution, to prepare pre-cut tissue and DMEC rolls. Briefly about history, so Dr. Patton, who did cornea surgery, does cornea surgery, you must have heard Patton spatula. It started in 1944. Again, Pride of India is, after 1 year we started in India, although it did not go in that how it went in US, and a successful transplantation was done in 60. So there is a lot paradigm shift in eye banking. We have more focus on utilization compared to collection. From moist chamber, we have gone to intermediate cornea storage solution. It was initially thought to be charity model. Now it is self-sustainable model. And the function of eye bank has increased to, rather than storage, preservation, distribution, to pre-cut and DMEC roll. So this is a graph showing the increase in corneal transplants as well as the pre-cut in RIAB, which is the largest eye bank in India. So as models, there are independent eye bank, and most of the eye bank in India are associated with hospital, and majority are dependent on HCRP, and some are dependent on voluntary, but mostly HCRP. So what I want to describe here is hub and spoke model, which started with transportation industry. Why it started? Because to scarcity of resources and intensive demand for profit, hub and spoke model was started. Why they can manage with less resources. I always think that iBank is similar thing, because iBank is a hub and you can have HCRP or iDonate collection center as spoke. So the hub manages client relationship, quality, whereas spoke is a delivery model. It is in different parts of the country, and they just supply to hub. The benefits are two. One is increased efficiency, second is enhanced quality. So the iBank, where I started my journey, is Drishtidan iBank. It has, it acts as a hub, and other spokes are many district headquarter hospital, although in future we have a dream to go to 30 districts. And again in the distribution, from Bhubaneswar it goes to many places in the country. Previously it was planned that one iBank can be enough for 20 million people, and each iBank can be linked to 40 eye donation center. There's no need of more than one iBank in each city, and each iBank can have HCRP in 10 major hospitals. So basically we don't need more iBank. To have a high quality iBank, the resources can be pooled and one city will have one, and the expensive infrastructure can be used for evaluation, preservation, and all those high-tech pre-cuts and DMEC roll. And this increases the efficiency of standard. Otherwise, many iBank, there's just for namesake it is there, and finally it closed down because of the challenges. So when Drishtidan iBank started in 2002, recently we completed 20 years, the dream was to promote eye donation and to combat corneal blindness only in Odisha. However, it has gone beyond that. So you can see the collection pattern. To start with, in 4 years, it is 30. So all those who are in iBanking sector, they know what are the challenges initially. So after I finished my cornea fellowship in LB Prasad, I came back to Odisha. There was no iBank. So practically 3-4 years, I have not done any cornea transplant. So I joined with them in 2002. I went for their collection and past transplantation. And then in 2006, when LBP came to Bhubaneswar, it joined together, and you can see the growth. So 1,500 was maximum collection in 2018. Then as for COVID, it has gone down. So this is only thing is the voluntary portion is very less, but we have very high utilization because of the HCRP. So the only thing worse than being blind is having sight but no vision. So I'll come to my vision. What should be the vision for the country? I'll say no waiting list for cornea blindness in India. Although most of the surgeons, they say they don't have cornea blindness, but I feel there are cornea blinds where cornea surgeons are probably not there. And as law permits, maybe in future we can export cornea to other countries. And eye banking activities are more in some states, whereas zero in many states it is zero. It should start in full swing in all the places, and we need more training center and more training center for technician as well as counselor. Like Dr. Basak mentioned that we have enough cornea surgeon to do the transplant, but the problem is the follow-up. Many times patients don't come for follow-up. So we need a lot of general ophthalmologists who can treat the cornea transplant patient. And more lamellar surgery, as I understand, there will be always the penetrating keratoplasty will be more, because the most common indication for transplant is microbial keratitis. However, maybe more lamellar surgeons learn that, and more lamellar surgery, and we should work towards prevention of corneal blindness. For that, we need epidemiological information about corneal blindness in different parts of the country. Maybe there should be change in policy which help more cornea surgeons to do cornea transplantation, because many people don't get the certificate or the quota registration for the cornea transplantation. Thank you.
Thank you, Dr. Sujatha, for a wonderful presentation, some very good inputs, some wonderful vision, and thanks a lot. So this concludes this session. I would like to thank all the speakers and all the colleagues who have been sitting here to participate in this session. So thank you very much, and very soon we'll start the next session.